Hi guys, welcome. Let's turn that off. Welcome. I'm so glad you guys are joining me today. We're going to be talking about pediatric growth and development. We're going to be focusing on some really key milestones and concepts that are frequently tested. Can everybody hear me? Some people are saying they can't hear me. They can't. If you can't hear me, it might be on your end, but let's see if everybody else can hear me. Okay, so it looks like I'm good on everybody else. Okay. So if you can't hear me, it might be something, an adjustment that you can do, have to do on your end. All right, well, welcome. Thank you very much for joining me. I am Megan. I have been a nurse for a really long time now. I have my background is primarily pediatrics. Used to work in the neonatal intensive care unit, and then I went back to some outpatient peds, and then I went to emergency medicine, both pediatrics and our adults. So I've got a mixture of both. Um, love every aspect of it. Love teaching. Love helping everybody. And I have the fantastic Jennifer in the Q&A. So if you have any questions, please put it in the Q&A. And if you are responding anything or anything questions that I ask, put that in the chat. Okay. So we have a real quick time frame. We're going to be here for the next 30 minutes together. We're just going to be reviewing some key principles of growth and development, applying some knowledge that we learned on some NCLEX style questions. So let's kind of dive in. But first and foremost, if I'm not loud enough on your end, try turning it up, turning your computer up. I'm sorry. Okay, so tell me, how does we do not do copies of the slides for our free webinars. So tell me, how do you guys feel about growth and development? I mean, sometimes it can be a little scary, right? Because they have all these little nitpicking things that we have to do, and there's so many different stages. Every different stage. It is hard. It is hard. Yes. So I'm just kind of hoping that, at the end of this time frame that we have together, that you feel a little bit more comfortable on it. It is very confusing because, again, every aspect, but let's think about it. When we're dealing with the pediatric patient, what is the first and main thing that we have to take into consideration? Does anybody remember? Weight is very important. Age, but is it chronological age? It's the developmental age, exactly, or developmental stages. So it is very, very important that we pay attention to those developmental stages and those developmental ages, because that is going to play a big part in how we have to approach those pediatric patients, right? So it's just some basic principles of growth and development. Okay, so if you understand these, it'll kind of help explain why children gain the motor skills the way that they do, right? So growth is quantitative, right? We all grow. We increase in our height, our weight. Kids, we measure our head circumference too, because it tells us so much information. Then we talk about the development part. The developmental part is the qualitative part. That is the qualitative progression in those skills and functions, such as our motor skills, language skills, cognitive skills. And there are some patterns of development. If I say the word cephalocaudal, what does that mean? Thinking back at our med terminology, cephalocaudal. Head, head. So head to toe. So we do head to toe. So cephalocaudal. So it's a head to toe direction. So let's think about our babies, right? When they're born, they're kind of floppy, right? They flop their head all over the place. They really don't have that nice neck control. So they have to gain that neck control and just their head control before they can sit up or walk. So that's that head to toe progression that we have to think about. And then if I say proximo-distal, what does that mean? What do you think I mean by that? Again, back to our med terminology. Near to far. I'll take near to far. Center to extremities. So they have to really control their core before they can go and control their extremities. So again, think about it. We have to be able to control our shoulders and our neck when we do that head control before I can control my fingers and do those very specific pincher grasps, right? So I had to do that. So when we talk about this progression, it is very purposeful. We have to do in that progression. Growth and development does follow a predictable order, but every child grows and develops at a very different state. So when the biggest thing that I think that a lot of people have when they're thinking about growth and development for pediatric patients is they compare them to either their own children or they compare them to other children, and we can never compare. Each baby and each child is going to develop completely on their own, so we can never compare them. They progress at their own rate and at their own time frame, right? So I can't say that, by the age of 9 months you should be taking 3 steps. I can't do that because every child is different. So some factors that develop and that influence our growth and development, we have to think about genetics. Genetics is so important. Our growth and development is very multifactual. Okay. So we have to assess many, many, many influences when evaluating our pediatric populations. So genetics is a big thing about that. So let's think about it. If the mom and the dad are a short stature, then chances are that child is going to be a short stature too, right? Nutrition is a big one. If our patients are malnourished during key growth and development stages, that can play a big part of it. Our prenatal and environmental factors. Prenatal talks about so much, right? We already know about when we're talking about OB that prenatally, if we're exposed to anything, it can really put make an influence on our patients and our babies that are growing and developing in the utero. Same thing when they're in extra utero. Our environment talks about so many different influences. Just think about where you live. Where I live, I need to make sure, I live up in the Northwest or Northeast, and it's been a really rainy Northeast summer so far. So, vitamin D deficiencies is a big thing around here because we have a lot of gray days and we have winters. We're not down in Florida or California where we have nice summer and vitamin D deficiency isn't such a big problem. Family and culture play a big difference. Just think about all the different cultural aspects that we can think of. Different rituals, different feedings, different food rituals, and things of that nature. And then health status and illness. Anytime that our patients become ill and we are in a hospital or we are having an infection, we can really be actually hindering and stopping that growth and development while they're in that. And that plays a big part of it also. So now let's actually dive into the different age groups. So who can tell me what the different kind of age groups we talk about when we're classifying them in time or symptoms of growth and development, and especially our developmental stages like our Piaget and our Erickson? Who remembers? Who can give me a couple of them? Infant. We have our infancy. Absolutely. Okay, so we have infancy. What's after infancy? Toddlers. Preschool, school age, and adolescent. You guys nailed it. Good. So we have our infancy, we have our toddlers, we have our school age, we have preschool, we have preschool, school age, and then adolescence. Excellent. Perfect. Okay, so now we're going to go and talk about each one of them. So infants, when I say infants, infancy is 0 to 12 months. So while they're in that first year of life, infancy, their growth and development is very, very rapid. My cousin just had a baby. She's probably almost like 6 months now. And every time that I see her, it's like something new is happening. Like it just facial expressions, the things that she's doing, it is very rapid. We really have to make sure that we're monitoring for those developmental milestones very closely because it is so rapid, so we can identify any delays early on so we can start intervening, right? Because we want to try to, if they have a delay, we want to intervene so we can they can have the best possible outcomes. Okay, so their weight doubles by 6 months and triples by 12 months. So they gain a lot of weight in that first year. They should roll over from 4 to 6, around 4 to 6 months. But I always have to remember that with their rolling over, we always roll from belly to back first and then back to belly. They should be sitting up unsupported at first, or supported at first. So like if they kind of sit up, they kind of like in that tripod position and they hunched over like this, right? Or with a pillow, or I used to use a boppy. Boppies are my best friend. Those around early first, and then they start going and sitting up unsupported, right? Again, still could be in that tripod positioning, and that's around 6 to 8 months. They should start crawling around 9 months. They really should start having their speech start developing, and they should have one to two words by 12 months. And those are not going to be, you know, hot dog or double syllables or two words. It might be mama, dada, baba, whatever. And now we have to talk about our two main developmental stages. We have Erickson and we have Piaget, right? So can someone tell me what Piaget's stages really focus in on? Who can remember that? Good. Thank you, Kristen. Excellent. Piaget is more on cognitive, whereas Erickson is more on what? What does Erickson focus on? Then so they're more. I could call it social if you want to call it so. It is kind of like a mixture of. It's more cognitive for our Piaget, and Erickson is going to be more psychosocial. Excellent, our psychosocial. Good. Okay, so Erickson, trust versus mistrust. This is kind of our building blocks of our psychosocial development. So trust. If an infant trusts the caregivers and they have constant caregivers, meaning that they have consistency in their caregivers and they are getting their basic needs met. Someone tell me, what do we think that some basic needs are going to be for an infant? What do they need? Feeding. Excellent. Diaper changes. Excellent. Bathing, nutrition, comfort, that bonding, sleeping, love, excellent. Okay, so if we are making sure that we are consistently meeting those needs, we're going to have some successful outcomes. If we are not meeting those needs, those babies are going to have that mistrust. They're going to have that fear and suspicion. We always want them to make sure that we're fostering the latter of the two. We want them to get that sense of trust and security. So let me tell you a real quick story because I know I have short amount of time. I'll never forget. I read a story about I don't know if it was like a reporter or a photographer. I don't know, but they were visiting a orphanage in China. And they went to the babies, the infant room, and they thought that this infant room, that these babies were so well taken care of because they didn't make a sound, right? There was no crying going on, there was no babbling going on, there was nothing like that going on. Whereas really the patients, the babies that were in that orphanage they weren't getting that bonding, they were not getting that, so they were getting that mistrust and fear. Because exactly, they gave up. Allison, excellent. They gave up because those basic needs were not being met. Perfect. Okay, so then let's go to shift gears and go to Piaget. Piaget is actually, this one covers infancy up through actually toddlers. It's that sensory motor stage. So this is really working on, they learn through those senses. So let's think about this. Anybody know that, that saying that a baby puts everything in their mouth, right? Because they are fixated on that oral stage, that they have, they're getting their nutrition via their mouth and sucking. They are getting their pacification if they use a pacifier or a binky, right? So everything goes into their mouth. So they're learning through that sensory input and motor activity. So really our key concept in infancy is going to be object permanence. So basically they're understanding that that object still exists even when it's out of sight. So peekaboo, right? Peekaboo. They love that game because they cannot understand that, oh, mommy disappeared when I'm playing peekaboo. So when we are in this stage, we want to really use toys that stimulate those senses and encourage that exploration. I'll never forget when my kids were little, I think it was my daughter, she used to have this little fish, it looks like an aquarium that had lights, but the fish moved around and like kind of floated around because it's stimulating those senses. Now let's move on to toddlers. Toddlers is 1 to 3 years old, right? So 1 to 3, they crave that independence. They Our temper tantrums start increasing around this because they're trying to navigate that autonomy. And you'll see that our Erickson stage is autonomy versus shame and doubt because they navigate that for that autonomy. And autonomy is our independence, right? So they want to be able to do it themselves. They can start climbing the stairs, their vocabulary is going to expand, and their toilet training starts to begin. Are they going to be masters of toilet training by the end of that? No, exactly. Potty training, yep. But we're just starting to introduce it. So then when we talk about autonomy versus shame and doubt, okay? So because they're striving for that independence, they're striving that we're trying to do that toilet training and that feeding. We want them to gain very confidence and self-control. So we want to try to foster that autonomy. When we do not foster that autonomy, the children are going to start having shame and doubt in their abilities to do stuff. They're going to have low self-esteem and self-control. I never forget the saying that, I can ruin a toddler's day by giving them the wrong colored sippy cup, and you can actually do it. I remember my daughter only would drink out of one sippy cup, and we had to wash it continuously because she wouldn't drink if we didn't give it to her, right? Because they want that control. So when we are as nurses, we are trying to foster that autonomy. How can we do it? We could, giving them control, giving them choices, right? So give them those choices, but we have to do it within that's still appropriate. So would you have to take this medication? Would you like to take it in a syringe or a cup? Okay. So we're still giving them those options and they still feel in control, but really we are the ones in control. So we talked about sensory motor with Piaget in toddlers. So this one kind of covers the next one, which is pre-operational stages. And this covers 2 to 7. So we're going to talk about it in toddlers and preschool age. But this is whenever their mind and their imagination starts going crazy, right? They are egocentric. They have magical thinking. So we need to foster that by pretend play, right? Who's ever played doctor or store or house or anything like that when they were little? That is what we are having that egocentric magical thinking. They like to they have limited ability to see others' perspectives, so they can't do that abstract thinking yet. That will come later on. So we really need to use simple language and allow expression through play. So at this stage, one of the best things that we can do is actually medical play. Does anybody know what medical play is? So medical play is like if I have to start an IV on my patient, I might have a doll that I'm going to do it on the doll first and then do it on the patient. Same thing as this, if I have to listen to heart and lung sounds, I might do it on the doll or do it on the mom, or I actually might have the patient. I've done it too many times. I've had the patient actually listen to my heart and lungs with my stethoscope so they can know what's going on with it. So now let's move on to preschooler. This is our 3 to 6 years. This stage is filled with creativity and curiosity. We really want these children to start engaging with storytelling and open-ended questions because they can start, their imagination is just going to keep going. So they can really start riding a tricycle. They can draw circles and people. Might not be the best people, but they can do that. We can start doing that imaginative play. They start learning cooperation in different roles. Initiative. So then we're going to talk about our Erickson initiative versus guilt. So our child initiates activities and asserts control. That's our initiative. They are actually initiating those controls. So in order for them to be successful in this stage, we need to allow them to initiate and we need to allow them to lead. So every time that I start, if I start barking orders at them or I um, correct everything that they're doing wrong, we need to kind of do that. And again, guilt is going to happen. They're going to start having have inhibitions if we don't allow that to happen. Medical play with a doll is appropriate. Yes, absolutely. Okay, so then Piaget, we just talked about that, right? So we're good with that. Now let's move on to school age. So that's 6 to 12 years. So this is probably the biggest range of age groups. They have a steady growth in their height and weight, and it kind of comes in spurts. So I always like to they have those growth spurts. Okay, they can start reading and writing. They start having those peer relationships. This age group thrives on achievement and socialization, right? They support their self-esteem with positive reinforcement. That's what we really need to do. So our Erickson stage is industry versus inferiority. So this is where we need to really focus on academic, social, and physical accomplishments. So kind of praising them for whenever they do good, they kind of like that. That's that reinforcement that we need to do. If we are successful in this, they have competence. They have pride in their achievements. And if they're not successful in this, they have feeling of failure or inferiority. Then we've actually moved on to our next Piaget stage. And this is our operational stage between 7 and 11. This is when that logical thinking starts to develop. They are tied to concrete objects still, but they're starting to logically think through it. So conversation, we can actually start having conversations with them. They have an understanding on quantity remains the same kind of. So how do you think what is best for us to interact with these kids? Being truthful for them, using hands-on teaching approaches and concrete examples. Then we have our lovely adolescents. I have a 13-year-old and I'm about ready to pull my hair out, right? That's when puberty hits. And we all know how fun puberty and hormones are, right? So I remember how I was whenever I was a teenager. I can only imagine what my daughter's going to be like. Now, I have a son who's 13 now, and it's like he's an alien sometimes. So I have identity information. They start doing risky behavior. Ready? They're doing that risky behavior because they strive to be independent and they strive to really have their own identity. We need to be very mindful on peer pressure and some mental health signs. So, like I said, I like to joke. My son is 13, and there's those hormones come into play and he doesn't know how to process in that. So at one minute he is screaming into a pillow, getting so angry he's shaking. And the next minute he's crying because he can't process those. So we really had to be careful because that can really comes up to me, he goes, Mom, I don't know what's going on. What's wrong with me? So we really had to be really mindful of those mental health signs. So, like I said, they are really trying to determine their independence and identity. So, of course, the Erickson stage is going to be identity versus role confusion. So, they're still starting to try to determine their personal identity and sense of self-being. So, if we're successful in doing this and letting them work out their own issues, they're going to have a strong sense of identity. If not, they're going to be very confused and have weak self-concept. Then we start having formal, operational, or abstract thinking in our Piaget, and this covers actually 12 plus. So they start having that abstract thinking and reasoning. So really those pros and cons, those consequences know what's going on. They start having problem solving and hypothetical thinking, so we can really kind of um, process more critical thinking skills. So as nurses, it's really good to start engaging our teenagers in discussion using those open-ended questions. We really want them to open up and talk to us about their feelings. I know no one likes to talk about feelings, but it's really important at this stage because they have so much going on with them. So it's really important for them to kind of process those. All right. So, what are some red flags in development? So these are some indicators that warrant some immediate referral or further assessment because early intervention is key. Remember, I said that earlier. So if they're not babbling by 12 months, they're not walking by 18 months, they don't have two-word phrases by 24 months. And we have to remember that regression occurs at times of stress. So if they're like if it's a new setting, they're in the hospital, they might regress to a previous developmental stage. But if they're not under a stressful situation and they have regression, we actually have to start figuring out what's going on with that. So, what are some NCLEX tips? NCLEX questions are going to often focus on whether behaviors are age appropriate. So we need to use those milestone charts during your studying. Talk about some of the things that we talked about here. Know what is expected in each milestone group and age group, especially those Erikson and Piaget theorists. Be alert for the scenarios that describe developmental delays. Remember at the very beginning of this, we talked about that our developmental age is key. And we need to match nursing interventions to the appropriate developmental level. Everything is based on developmental level at this. That's a very good question, Christine. Christine asked, what age do they experience regression? It can happen at any age. I have seen it in preschool. I have seen adolescents do it. I've seen adults regress. So it can be they can regress at any age. All right, so we've got a couple of minutes left. Let's look at this. Let's do a first question. A nurse assesses a 9-month-old. Which milestone should the infant have achieved? Remember, we do not do PowerPoint presentations for our free webinars. All right, 9 months. Think about that. They're going to be C, right? Sitting without support. Walking independently, no, that doesn't come until probably after a year. They should only be saying 1 to 2 words within that by 12 months, and they're not using a spoon independently. So sitting without support is our goal. Remember, that happens between 6 to 8 months. Excellent. So this question assesses knowledge of normal development, right? All right, number 2. A 4-year-old is hospitalized. Which toy is most appropriate for a 4-year-old? Let's think about a 4-year-old. All right, so think about it. Remember, preschoolers, they're very creative. We're fostering that autonomy. So D is going to be the appropriate one, having them to be creative. Oh, that color is not going to work today. So coloring book with crayons. A picture book would be good for early toddlers, but not our 4-year-olds. Excellent. Okay, next one. All right, a nurse teaches parents of a toddler about discipline. What should be included? Excellent. Remember, toddlers respond well to structure and consistency. So we want to use consistent age appropriate discipline. Excellent. We don't want to do physical punishment. We need to avoid any punitive measures and focus on the teaching, right? Okay. All right. So in summary, let's look. Move that back. Growth and development are foundational in pediatric nursing. We have to understand our growth and development. We need to understand how those patients are developing. Understanding the milestones for each age group is a big one. Apply knowledge to NCLEX style questions, just like we did. Think safety and development on our NCLEX, just kind of like we did, and recognizing those red flags in early interventions. All right. Does anybody have any questions? Someone asked me about the slides with the red flags. Yep. Question one. Question one was about our 9-month-old sitting without support because they should not be walking independently. Walking just starts around 12 months, and that's not independently yet. They only say about 1 to 2 words by 12 months, and they're not using a spoon independently yet. So this video will not be reposted, and to rewatch. I wish we could do 2 more practice questions, Gabby. I'm sorry, but we're out of time. All right. I thank you guys so much for coming. Remember that we here at Archer we do across the light nursing lifespan, pre-nursing all the way up to our post nurse practitioner and master's degrees. Excellent. Thanks, guys. Yeah, real quick, pre-operational. Let me go up to pre-operational. So our pre-operational is whenever they're having that egocentric magical thinking and they're very symbolic. So let me put an example real quick. My husband's grandmother passed away. My son was 4 years old. He has that magical thinking, but very, very symbolic. Like it is, we told her that she went to heaven. So when we went to the viewing, her body was here at the viewing. And so when my mother came to pay her respects, he took her to say, you know, we called her Grandma D. Grandma D is in heaven. So he's like, well, we're in heaven too, because that's what they're thinking, because they've that egocentric, that magical thinking. Barcode? I don't have a barcode. This barcode? The SurePass combo? Is that what you're asking? Okay, perfect. Okay. All right. Well, thank you guys. I really appreciate what's going on, or that you guys got to join me tonight for a little bit. If you need anything, you know how to get in touch with us. We do these free webinar Wednesdays, so I hope you can come back again in the future to see another webinar.